Well, good evening, everyone. Welcome to the Kingsway Talks this evening. My name is Patrick. I'm the rector of All Saints Kingsway Anglican Church here at the corner of Prince Edward Drive and Bloor Street. We're so glad you're here. This series of talks, of which this is the third, they arose in conversation with Prince Edward Medical as we sought to discover and meet felt needs of our community here in the Kingsway. It's a wonderful partnership with the clinic, which we hope continues into the future post-COVID. We are, as they are, committed to the well-being of this neighborhood in body, mind, and spirit. Like our friends at Prince Edward, we have a deep stake in the flourishing of this community. And so here we are tonight talking about issues that we all care about. I'm going to have one of our lay leaders, Natanya Friesen, say a few more words of welcome and introduction before we get to our guest speaker tonight, Dr. Haley McInnis. Natanya, over to you.
Thank you. So good evening, everyone, and welcome. My name is Natanya Friesen. I'm a member of All Saints Kingsway Anglican Church, and I'm a longtime resident of the Kingsway community. I am so glad to be here tonight. I'm really looking forward to hearing what Dr. McInnis has to say and to the question time afterward. I am sure that many of us here have been impacted either directly or indirectly by the toll that dementia and Alzheimer's takes on individuals, on families, and especially on caregivers. And so it'll be really good to have this time together this evening to talk about this issue. So I'm going to pass it over to Brian now.
Hi, everybody. Thanks so much, Natanya. We're really glad you're here with us tonight. This topic is one that's really close to my own heart as I'm walking with my dad through the beginnings of dementia and doing so from a distance. It's really, really difficult. So I'm looking forward to hearing from Dr. McInnis tonight. Before we begin, just a few housekeeping items for you to be aware of. Please do post your questions in the Q&A box at the bottom of your screen. You can do so anonymously if you choose. At the end of Dr. McInnis's presentation, we will ask your questions and give her the opportunity to respond. Also, at the end of the session, there'll be a quick poll come up on your screen. Give us your feedback. Let us know what you think, and feel free to reach out after today's session if you have further thoughts that you'd like to share. Last, the webinar is being recorded tonight, and it will be posted on our YouTube page tomorrow. An email will come to you with the link and with a list of resources shared in tonight's presentation. Dr. McInnis, thank you so much for being here. Thank you for sharing with us tonight. We're going to turn things over to you now.
Thank you so much for that lovely introduction. Good evening, everyone. My name is Dr. Haley McInnis, and I'm a family physician at the Prince Edward Medical Clinic. Share my slides. Okay. Excellent. Yes, so a little bit about me. I grew up in Aurora, so just north of the city, trained at the University of Calgary for medical school, and then came back to Toronto and trained for my family medicine residency at the University of Toronto. I'm very happy to have been asked to present on this topic of dementia. I hope my talk today can give a deeper understanding of dementia and Alzheimer's disease. For those caring for loved ones with dementia, I hope I can provide you with some advice, guidance, and support in how to manage and what to expect in caring for those with dementia, some of the common symptoms. I want to thank Reverend Brian Suggs and All Saints Kingsway for giving me this opportunity to present tonight. Okay, here's a brief agenda as to what we'll be covering. So I'll be spending about 40 minutes going through these topics, starting with defining dementia, the types of dementia. Then we'll move into the behavioral and psychological symptoms of dementia, some strategies you can employ at home, how to get support, and then into our Q&A and discussion period. I'll take about 40 minutes going through the slides. At any point, please post a question if it comes to mind into the Q&A, and we'll have time for the questions at the end. What I might not be covering today is the biology or pathophysiology of dementia. So what's actually happening in the brain. And the reason I'm not covering that is that it doesn't have significant impact on how we care for those loved ones with dementia. And it's often a clinical diagnosis what requires just a conversation with your doctor about what you're experiencing, what your loved one is experiencing. Sometimes doesn't even require any head imaging to come to a conclusion. As Reverend Suggs mentioned, he has a connection to dementia, and so do I. So this is my Nana and a picture of me when I'm much younger. My Nana had dementia, had her own apartment, but did live with us for about 6 years when I was growing up. In the early stages of her disease, she was able to do some childcare, some simple food preparation, but often would choose to retire back to her apartment when things got a little hectic at home. As you can imagine, it can be quite overstimulating for someone with dementia to be in a home with 3 young kids running around. In the later stages, she became more dependent, requiring Meals on Wheels in order to remind her to eat during the day. As a young child seeing this, it was frustrating at times, not understanding why I needed to repeat myself or why maybe my Nana was acting strangely. But my parents did a good job of explaining it, and I really do cherish the memories I have seeing my Nana during those times. So before we can understand dementia, I'd like to discuss what normal cognition is, what the brain is able to do when it's functioning normally. Cognition is more than just memory. It's the brain's ability to acquire knowledge and understanding through thought, experiences, and senses. Scientists break down the brain's complex processes into different cognitive domains listed here: learning and memory, language, executive function or planning, attention, and visuospatial skills. Your brain is responsible for many things simultaneously, some things that we wouldn't even think to give it credit for. For example, as you're listening to this presentation, your brain is responsible for hearing the words I'm saying, understanding the meaning, remembering the concepts, and making connections to your own personal circumstances. You know that the information you are reading on the slide belongs to a larger presentation on dementia, and you're able to pay attention to the presentation while simultaneously thinking about the dinner that you had and how you may have skipped dessert, and we'll have to attend to that at the end of the presentation. Your brain is doing all of these things at the same time. So while memory and learning is often the most commonly affected domain in dementia, there are other domains that can be affected as well. This might help you appreciate the challenges that a person is facing when they develop dementia. Okay, so what is dementia? So dementia is defined as the decline in cognition from a previous baseline, which impacts the person's ability to perform everyday tasks without help. So there are 2 parts of this definition that I want to highlight. One is the decline in cognition from a previous baseline. So that pertains to the cognitive demands and domains that we spoke about earlier. And the second part is how it impacts the person's everyday function. In healthcare, we call this the functional impairment. So on this slide, we are focusing on the cognitive domains of earlier. Learning and memory. Someone with dementia might forget names or misplace items. Language, finding words or naming objects, like, can you please pass the remote, right? Understanding instructions. Remember, language is not just expressive, but also receptive. So when we hear language, how do we process it? That can be challenging for someone with dementia. Executive function or planning, so problem solving, making decisions, adapting to changes in routine. Attention, completing a task in a timely fashion or multitasking. And visuospatial, so hand-eye coordination, using tools or even doing up buttons, and recognizing people and objects. Remember, when someone with dementia sees a face, process that as a person. They won't be able to attribute that face as to someone they might know. And that can be that can make them suspicious, as it would anyone. And then secondly, the second part of that definition, the impact on function or the functional impairment. So a lot of these cognitive domains do get harder as we all get older. But dementia is not a part of normal aging. The difference is that second part, the functional impairment. It is part of normal aging to sometimes forget names, especially of acquaintances, or for example, a resort that you stayed in last year. But if you're forgetting your home address or the names of close family members, then it is more concerning and could be a sign of dementia. So when we think of functional impairment, we think of the everyday tasks that someone needs to perform in order to function in our society without assistance. This first list is called the instrumental activities of daily living, which are a little bit higher level than the next list. Things like using the telephone, shopping, preparing food, housekeeping, doing laundry, using transportation, handling medications, or handling finances. Now, some of my patients who are in their older years decide to delegate some of these tasks just to make life easier. Perhaps they have dutiful family members who are happy to take these on, or some physical limitations that make this harder to do. However, someone with dementia wouldn't be able to do many of these tasks. Here is a list of more basic activities of daily living. As you can see, this list is much more rudimentary. Things like feeding, continence, transferring, toileting, dressing, or bathing. For someone with severe or even moderate dementia, they would need assistance in some or all of these categories. Now, if a person with dementia just needed help carrying out these tasks, then caring for someone with dementia would be a lot simpler than it is. But there are some symptoms of dementia that are not captured by the cognitive domains, and there are some needs that are not captured here. Every person who has cared for someone with dementia knows that there are mood changes, behavior changes, and even personality changes that are seen in people with dementia. This list is considered the non-cognitive symptoms of dementia. They are so common that there's a term for them. They're called the behavioral and psychological symptoms of dementia, or BPSD. They occur in about 90% of people with dementia and prevail at all stages and all types of dementia that we'll discuss later. There are different symptom clusters, and each with an important safety concern. So first, apathy. This is the lack of motivation or interest. They may be withdrawn, and this can be a concern for self-neglect. Depression, so low mood, feeling anxious, hopeless, guilty. They might be irritable, sad, or tearful. There's concerns for self-harm behaviors or even suicidal thoughts. Agitation, so restlessness, wandering, dressing and undressing, pacing, repetitive actions. There can be a concern for wandering or again harm to self or others. Aggression, so defensiveness, resistant to care, verbal and physical abuse. Again, concerns about safety. Mania, so this is when your mood is too high, feelings of euphoria or irritability, pressured speech. This can be quite distressing to the patient and caregiver. And finally, psychosis, so hallucinations, seeing things or hearing things that aren't there. Delusions, ideas that don't really make sense, but the patient feels very certain and confident about. Maybe some suspicion or paranoia. There are many types of dementia. We use dementia as a catch-all term that generally means progressive neurodegenerative diseases. But there are different types of dementia. Alzheimer's disease, being the most common, is more likely to have certain behaviors than others. Behaviors like apathy, agitation, depression, anxiety, irritability. Lewy body dementia might present with hallucinations. That can be an indication to a clinician that this person has Lewy body dementia. Frontotemporal dementia, so this affects certain parts of the brain, the frontal cortex and the temporal lobes, can present with apathy, disinhibition, and elevated mood. And finally, vascular dementia, caused by the same vascular disease that would cause a heart attack or a stroke, can also cause dementia. And so that might present with depression and apathy. As you can see, there's a lot of overlap here, but identifying the type of dementia might identify the unique needs that an individual would have. Why are these behaviors happening? Well, unfortunately, we don't know. There are several theories as to what might happen, but what's really important is that we need to know whether or not the behavior has meaning. It's possible that these behaviors are just symptoms of dementia, just like how trouble finding words is a symptom of dementia. So could anger or apathy, irritability. Those behavioral changes could just be other symptoms. However, it is worth brainstorming solutions to behavioral issues by asking, does the behavior have meaning? Which means, is there an unmet need or some underlying issue in the environment that we can change and the behavior might improve? Exploring meanings can help identify how the person with dementia is responding to their environment. And your doctor and your home support workers can help with that. There is a rubric that clinicians use in order to identify some possible causes to behaviors associated with dementia. This is called the PIECES model, PIECES, it's listed there. And each letter stands for a different possible cause. P for physical, then intellectual, emotional, capabilities, environment, and stimuli. It's a perfect way to try to brainstorm what someone's unmet needs might be. So physical causes, disease. So if you come to your clinician with your loved one, and your loved one with dementia has a new or worsening symptom, this is something that your clinician will try to rule out. Are there new physical symptoms? And you can do your part by trying to list and identify what new symptoms have occurred and when did they start. For example, does your loved one have a cough? Or maybe they're peeing more frequently, and that could be a sign of a urinary infection. The reason this could be helpful is because if they do have a urinary infection, you might notice that they're wandering more at nighttime because they're trying to get to the washroom in order to urinate. So the wandering behavior might be because they have an underlying urine infection. Discomfort. A person with dementia might have a difficult time expressing their needs. Perhaps they're in pain or constipated. Maybe they're retaining urine, hungry or thirsty. This is when we need to focus on our nonverbal cues and hopefully establish a routine so that these needs don't go unmet. For someone in pain, you might see that they're wincing, right? And then you'd wonder, okay, is there something that's causing pain? Disability. A lot of older adults have low hearing or low vision. If your loved one with dementia normally wears their hearing aids or normally wears their glasses, this is something that can be corrected. Someone who can't hear or can't see will easily disengage in a conversation. And then you'll notice that if they're not engaged, they might get more confused or disoriented more easily. And finally, drugs. So this being medications that they're taking, okay? Your clinician can, again, assist with this. It's important to talk to your doctor at least once a year about medications your loved one's on or any other new issues. Intellectual causes. So these will be present in someone with dementia. Knowing these terms will hopefully give you a deeper understanding of what someone with dementia is struggling with and compassion for why they might have certain behaviors. There's a whole list of A words coming at you. So this is amnesia. This word means memory loss. So this is something that's very common. Probably most people think of this first when they think of dementia, memory loss. So initially short-term, so recent memories, and then progressively can be more long-term. Amnesia or memory loss can be a source of a lot of caregiver frustration, right? Aphasia. So this is problems with speaking, producing speech, but also receiving language. People who have trouble communicating or understanding conversation may withdraw socially due to shame or frustration. May lead to misunderstandings as well. Apathy. So this is the loss of drive to initiate activities. Again, a symptom of dementia. Not necessarily is your loved one depressed. If they aren't reporting sadness, they might just be apathetic, which means that they need some encouragement in order to do the tasks that they say that they're interested in doing. You just need to encourage them to physically get up and do it. Agnosia, so the inability to recognize and attach objects, faces, smells, and tastes to meaning, or more simply, the inability to recognize everyday objects and people. This can be, again, a source of frustration with caregivers or sadness if your loved one doesn't seem to actually recognize you. There's also a chance that they might use wrong objects when they're supposed to be carrying out tasks, such as a toothbrush as a comb. This could be a safety concern if they're using, let's say, a razor as a toothbrush, right? Apraxia, so the loss of ability to plan, initiate, and sequence movement. For example, you might see that your loved one is putting their shoes on before their socks, or not able to actually do their buttons up. This can be, again, a symptom of dementia. It doesn't mean that they're being difficult, right? This is just their disease. Anosognosia, so this is poor insight into the disease leading to poor judgment. Your loved one might not understand that they have dementia, right? So for them, they're trying to do things thinking that they're capable like they used to be, okay? And so that takes a lot of compassion and understanding to facilitate that, but also making them feel like they're still worthy and independent. And altered perceptions. So these are speaking to the changes in visual spatial cognitive domain. Surfaces might appear deeper than they are. For example, if someone getting into a bathtub, that might be a very scary task because they're not able to actually perceive how deep that pool of water is, right? Or maybe they're hearing the radio and they think it's a real person sitting there with them, talking to them. They see a coat in their closet and they think that's a person. Maybe there's a very difficult pattern on the carpet and they're having trouble walking over the carpet because their brain doesn't make sense of it. Okay. So E for emotional. Again, very common in dementia for people to have mood changes, depression, grief, frustration, paranoia, or suspicions. Attending to those emotional needs is going to be important. Taking a very gentle approach, a loving touch, a calm, collected voice. It's going to be very important for a patient to feel comfortable. Capabilities. So these might be too high or too low for the environment. So consider the demands that we are placing on our loved ones with dementia. Are they reasonable considering their needs and their capabilities? So for example, is it reasonable for them to be independent to create and produce their own foods? If not, then maybe we need to be taking over that task. However, sometimes we can actually be giving too much and not giving the loved one enough chance to exert their independence. For example, bathing. Do they just need help getting into the tub and then they're able to clean themselves? If we're assisting in bathing, a loved one might feel shame or frustration because it feels like they're not able to actually do it themselves. They have the capability, but we're not giving them the opportunity. So checking in with them and really getting a good sense of evaluating their needs and their independence will be really important. And again, your clinician can help with this. Environment. Consider changes in environment. Is there a new or worsening behavior? Was there something that changed in the environment? Maybe the new tapestry on the wall is a little too hard for them to understand, or maybe there's now a lot of construction next door and it's just too loud at the house. Okay, so think of the non-human environment and also the human environment. Is there a new person coming into the house? Are your grandchildren coming more often? And that's just a little bit chaotic for someone with dementia. Okay. And then finally, social. Think of the person's social network. Are they able to see their friends? Are they someone who likes to socialize? And if not, that's okay. You know, we want to identify that this is still a person with their own needs and their own personality. What activities do they like to do? Are they able to do them? And is spirituality important to them? Are they able to stay connected to church and practice their faith? There are some high-risk behaviors that I want you to be alerted to, and these would be reasons to seek help from your family doctor, or if it's urgent, to go to the eMERGE. And you can think of these as risks. R, roaming, wandering, getting lost. This could be a safety hazard if we're not able to find a person with dementia, especially in the weather being so cold outside. This might be a good time to register your loved one with a medical alert. There's a registry of patients with Alzheimer's disease who the list of will be provided to the police. So if in case of wandering, they can be identified. Imminent physical harm. So think of fire hazards. Maybe you need to be turning off the stove or unplugging it during the day. Hiding the knives from the knife block, or any risk of falls. So also some loose carpets, or what's on the bottom of their shoes. Is it non-stick, or is it stick? Sorry, so that they're sticking to the floor so they don't fall. Suicidal thoughts or non-accidental self-harm. It can be very difficult for someone to go through dementia. There are going to be times where they're lucid, they're a little bit more aware, in which case it can be a grief reaction, right? Losing their capabilities at the end of their life that way. So just be on the lookout for any expressed suicidal thoughts or attempts at self-harm. That can be treated with medication to help your loved one. And be mindful of yourself and other caregivers, right? It's very demanding to care for a loved one with dementia. And you might be doing everything you can, but everyone needs some help sometimes. So be mindful of your own safety and your own capability. And self-neglect. So not eating, poor hygiene. These are things to look out for a patient. Maybe it's time to get a personal support worker in to help with bathing, for example. At your appointment with your doctor, do prioritize these things first. There's a lot to talk about, of course, but make sure that this is on the forefront of the appointment so we can address it adequately. Okay, so now some strategies for management. Overlying principles, whenever there is a behavior that is unwanted or seems distressing, the first thing I want you to think is safety. Are you safe, and is your loved one safe? So when you're addressing someone who might be agitated or aggressive, stay near the exits, remove any dangerous objects or ongoing triggers, and withdraw if you're feeling unsafe. You can always call 911 if you're feeling unsafe with someone with dementia. Environment. So I want you to think of reducing environmental stress, keeping everything gentle, quiet, or even some calming music. The brain really does respond well to calming music, as we can probably all agree after hearing that lovely music before the presentation. Adjust the stimulation. Think of the lighting. Is it too bright? Can it be dimmer? Or is it too dark and your loved one with low vision is having trouble navigating the environment? Is there a TV on in the background that's just a little chaotic, right? Or lots of traffic from the street? Enhance their function. So if there's anything small that is really difficult for them to manipulate, maybe you need to think of larger appliances or rubber bowls to use, things that can be easier, bigger handles on any spoons or other cutlery. And prioritize comfort. Think of what they're wearing, what they can do to just feel more comfortable in the environment. If you're approaching a person with dementia, use a calm, slow, compassionate approach, okay? A calm tone, a gentle hand can go a long way, smiling, and redirect the person to new activities. Do try to establish a routine at home so the patient with dementia knows what to expect at every time. Remember, that brain responds more to stress than another brain might, right? So anything that's stressful could be very difficult compared to something that might just be mildly inconvenient or annoying to another brain. So more specifically, let's look at an example. Let's look at agitation as an example behavior. So what are some possible meanings for agitation? Someone who's restless, wandering, roaming, pacing. Okay, well, is there a mismatch between the person's capacity and the demands presented? Are we asking them to do too many things at once? Do we give them too many instructions? Is it too chaotic in the environment? Fear, uncertainty, these could be some emotions that are coming out for someone who's having trouble processing what's going on in their environment. Maybe there's some discomfort. We need to consider, disease or medications. Are they in pain? They could be overstimulated, but they could also be bored. Again, we need to think of what is this person actually capable of doing and what are we requiring of them? And then finally, frustration. And that again could be that mismatch between what they're capable of doing and what demands are presented. So some strategies. Again, adhere to that routine so that they know what to expect when. Play some soft music in the background. Reduce noise and clutter in the environment. Use a calm, warm tone when approaching. Use short sentences to communicate so it's easier to follow your instructions. Avoid asking any questions. Again, it might be hard for the person with dementia to express themselves or even really process what they're feeling. And use nonverbal communication like a nice smile or a gentle touch. Strategies for suspicion. So possible meanings. Sometimes with someone who is suspicious, it's because of memory loss and disorientation. They don't know where they are, they can't place themselves, and then they might not be able to actually recognize the face in front of them. They have an unrealistic concern or fear about future harm. Maybe they're unable to recognize people, but their brain still is trying to make sense of what is happening around them. So they might have hallucinations that are confusing them or delusions. So for example, hallucinations, seeing things that aren't there, who is that in the corner? Well, that's just a coat. Maybe we need to close the closet door or remove the coat. Or thoughts, I think someone stole my purse. Okay, well, why don't we look for it together? And as you look for it together, you can try to redirect them. Or maybe there's some objects, if they continue to think that they've lost their keys, just bring some duplicate keys. You can say, hey, here are your keys. So possible solutions, again, adhere to a routine, really important for a variety of different behavioral presentations. Remain calm, provide reassurance, do not argue. Again, their brain is trying to make sense of their environment and it's going to make connections in different ways. Kind of like when we're dreaming, we make connections that don't actually exist, but they're based on the images we're seeing when we're sleeping. If the individual believes objects are being stolen, you can create the duplicates and help the individual to look for the items, then try to redirect or distract them. If there's TV on the background, that can trigger confusion. Is that someone talking to me in the background? And then you can always use a behavioral log to identify any triggers that you may not be aware of. Okay, so how to seek help. So first of all, your family doctor and the family doctor of your loved one is here to help. And maybe aware of some resources that you're not aware of. So do call your family doctor and stay close by, okay? Reach out to community programs for support and education. And I have listed some at the end of the presentation with their websites and their phone numbers that you can contact. Contact the CCAC, so this is the LHIN, the Toronto Central LHIN, to discuss health needs and eligibility for long-term care. There's their number there. The CCAC doesn't only help you apply to long-term care, but can also provide some home care. A care worker will come and discuss your needs, meet your loved one, look at the home, and may say, hey, I think you should have someone come in twice a week just to help provide care. And this would be OHIP covered. They can also do what's called an occupational therapy home assessment. Maybe your loved one would feel more safe at home, or maybe you'd feel more safe if they have guardrails for their bed or bars to help them lower to the toilet, or even a toilet that's a little bit higher. If there's stairs at home, maybe there's something that can actually help them move up the stairs. Those things kind of helping the function of the environment. The occupational therapist, this is their job, so they're very keen and very diligent about what's going on in the house. Decide on power of attorney for personal care. So maybe with someone in mild dementia, they could still identify their wants and their desires, who's going to take care of their finances or their personal care when they're no longer capable of making those decisions for themselves. Having those conversations early and having some legal documentation on these things will be very helpful to all of your care providers. And then finally, goals of care. There's the Ontario website to discuss future planning. So what sort of things and interventions does your loved one want if they have to be hospitalized? Do they want to be resuscitated? Do they want to have a non-invasive death? These are things to discuss early, just so everyone's on the same page when you're, in case you're in a place you have to make a decision for your loved one. Caregiver burnout. So again, you need to take care of yourself so that you can best take care of your loved ones, okay? So please do keep in mind your own needs. If there's ever a sudden change in behavior and you don't know how to cope, you can always call 911 or take your loved one to the emergency room, okay? If you feel like your needs are greater, or needs of your loved ones are greater than you can provide for, please ask for help, either from your clinicians, directly from the CCAC, or to the support groups at the end. Sometimes your clinician might even suggest that we use some medications to help your loved one with dementia. And the reasons they might suggest medication would be if non-medical therapy options, like what we've discussed, are unsuccessful at managing the behaviors. If the symptoms are likely to respond to medications. So in symptom clusters of agitation, aggression, psychosis, those sort of symptoms are likely to respond to medications. If the symptoms are distressing or dangerous, this would be a reason to consider medications, or if there's an imminent harm to self or others. The medications are in the antipsychotic category. Okay, this does not mean that we think your loved one has developed schizophrenia or something like that. This is just a symptom of dementia that we're trying to manage so that your loved one feels more comfortable in their environment. It can also help with sleep too, so that's another benefit to these medications. What if my loved one is hospitalized? So this can happen for various reasons. Oftentimes people with a fragile mind, because they have dementia, are at risk of delirium, which is an acute and fluctuating course characterized by inattention or changes in their level of consciousness. So someone who develops delirium, which people at risk with dementia are at risk for, might be hospitalized. So what do you bring? It's a good idea to have these things ready in a to-go bag, okay? First of all, medical information, a list of their current medications and allergies, a list of their medical conditions and previous hospitalizations, names of their doctors and all involved specialists, and their decisions on goals of care. More specifically, if that term's not familiar to you, there's that Speak Up Ontario website listed earlier. But this basically means, are we performing CPR? Are they coming into hospital? Are they for just medical management, or are they also for resuscitation? And comfort items, this can go a long way in reassuring someone in the hospital. Nowadays with COVID, it's very hard and our loved ones are more isolated than ever before. So any items of comfort can go a long way, whether it's a blanket or stuffed animal that's meaningful to them, a clock to display the time to keep them oriented, some family photos, and if your loved one responds to music, a music device and headphones that the nurse can help set that up. Of course, you're going into hospital, it's a crazy place, items might get lost, so please don't bring anything that you can't replace. Another thing to consider is when they're admitting your loved one to hospital, consider asking for a window room. And what I'd like you to say is can my loved one have a living room? Can my loved one have a window room? Because they get easily confused. And hopefully the nurse and the care team recognize that they're at risk of that delirium, and they should be at the window to help them get oriented, as opposed to just because it's nice to have a window in your room. Okay, so now a list of resources. These are fantastic websites. This is one of my favorites, the Alzheimer's Society of Toronto. Their website is listed there, but if you Google Alzheimer's Society Toronto, you'll see the Toronto chapter, you'll see Ontario. There's so many resources on this website, I can't recommend it enough. You can click on make a referral to actually refer your loved one to the Alzheimer's Society. And this is an excellent society. They know that your loved one might not be able to receive a call, so you put your number on so they can contact you. You can self-refer, or you can ask your clinician for help. Click on Learn for free workshops about Alzheimer's disease and other forms of dementia. and click on Discover for support services too. You can contact them by phone or email as well. For the Etobicoke Senior Services, this is local to our community. There's their website located, and click on our programs and services. Many of my patients rave about their services, so please do connect your loved one. Even during COVID, there are virtual ways of connecting, and this lockdown is not going to last forever. So soon the Senior Center will reopen, and that will be an excellent way to stay connected. Again, there's their phone number and their email address. And then finally, Canes Community Care. So this really helps, especially with behavioral management. People can give support and advice at Canes. There's their website, and click on Behavioral Support Services. And there's other resources there as well. Again, their contact phone and email. All right, so that brings us to our Q&A. I just want to point out that the pictures I used in this presentation are all from a lovely initiative out in the Netherlands. It's called the Kingsway Dementia Village. And it's an entire fabricated village where the care workers work in it. And all the individuals there have their apartment, but they also can safely walk about the village. They can go to the bus stop, but safely knowing that no bus is going to come and take them away. They can go do some grocery shopping, and it's all staffed by care workers with training in dementia care. So it's a really lovely way for someone with dementia to still interact with their environment, but do so in a safe way. All right, and thank you very much.
Dr. McInnis, thank you so much. That was great.
Well, thank you so much. It was very great to go through this, and I really hope that people find that valuable and give some support in what's a very difficult task, caring for someone with dementia.
Indeed. We do have some questions that have come in, and if it's helpful for you, Dr. McInnis, to see the questions you're going to respond to, you can click on the Q&A button on the bottom of your screen and see the questions, but we'll read them out just because the participants can't see them as well.
Sure, fair enough.
So the first question here is, how do you know when your care for a loved one deserves better than you can give or provide to them? How much does not caring well affect the loved one with dementia?
Mm-hmm. Yeah, I think there's a lot to unpack there, right? So first of all, there's really two people. Whenever I see a patient with dementia, I also see their loved one. And I think of this as two different patients and with two different people with needs. And one is the loved one with dementia, but also then the caregiver, right? And the caregiver can come with a lot of guilt. Feelings of, am I doing enough for my loved one? You know, when there's marriage for so many years, you know, you're together forever and you have certain promises to each other. And just so you know that you are doing enough. You are doing enough by providing with love. And if there's ever a time that you feel like it's too much, then that's the time that you ask for help. You can trust your own judgment there. Okay. And just know that this is a very devastating disease. And if your loved one is safe and you can give them as much comfort as you can, some behaviors are going to be more difficult to treat than others. But I think having a really strong relationship with your family doctor or other care workers, that'll be much of a guide for your own unique needs. There are community supports out there, and so please do take advantage of them. I hope that answers the question, but happy to get a follow-up question to that.
We have another question here. Can a change in environment make decline speed up? And is this temporary or permanent?
Good question. So happy to say that the progression of dementia will not be environmentally mediated, meaning that any change in any change in environment that causes a worsening behavior, if we alleviate that change, the behavior should get better. That being said, we know that underlying this, we're talking about a disease that does progress over time. And certain diseases, certain dementias progress in different ways. some slowly, or some actually incrementally, where you notice that in vascular dementia, for example, if there's another clot or another part of the brain tissue that is no longer functioning, then you see a function level from here that drops to here and then drops to here. It's stepwise. So the changes to in the environment, it might just be coincidental that one change to the environment, like bringing in a couple of new houseplants, all of a sudden the patient's a lot more confused. You remove the houseplants and they stay confused. That's likely just a progression of their disease and not something that was caused by a change in environment.
Wonderful. Thank you, Dr. McInnis. We had a couple of questions emailed in earlier for tonight's session. So this participant says, my husband is in long-term care. He has dementia. I normally go to see him 5 or 6 days a week. Lately, he's been accusing me of lying to him and asking me not to visit him anymore. He says, I thought I asked you not to come in anymore. Sometimes as soon as I get there, sometimes 30 or 40 minutes into the visit. He says it in a very cool, calm, and collected manner. I tried distraction, which works for a while, but then he says it again. I usually leave then. So my visits have gone from all afternoon to 30 or 45 minutes, or even less sometimes. Do you have any suggestions on how to deal with that type of situation?
Yes, okay, thank you for the question. And I'm very sorry to hear that. I think that might be very distressing to you as a loved one visiting and doing well by your partner. Please don't take it personally. This is not him, this is the disease. And there are some strategies that we can use. So one, think of talking to his care team at the long-term care. Are there times where he's a little bit more elevated, happy, social than others? There is a concept called sundowning, where people with dementia actually have more of a disorientation and get a little bit more worked up around the evening time when the sun's going down. So you might want to consider doing your visits a little bit earlier in the day. He might just have a little bit more of that boost of energy and feeling a little bit more himself at different times. So you can experiment with when you visit. It sounds like what you're describing might be the symptoms of paranoia or suspicion, in which case using a gentle tone, not feeling like put off by it, he might just have trouble recognizing you. And even just in that instance, maybe he sees you and he feels guilty or he feels ashamed, which is sad to say, but that might be coming more from inside than how he actually feels about you. And so I think if it's important for you to stay connected to him, which I believe that's very important. Try varying the times that you visit. Don't take it personally. Redirect him or distract him with a change of conversation. Try to do something very simple together and avoid asking him too many questions that he might have a hard time processing. Think of the things that you do comfortably together and some things that might frustrate him, and avoid doing something like that. Perhaps there's a game you could both do together, a simple tile game or something to spend that time. And talk to the care team. They see him 24 hours a day and they might have some suggestions as to when he's feeling in a better mood.
Thank you so much, Dr. McInnis. We have another question, and this one is about capacity assessments or tests. The question is, when is a capacity assessment required and what is the benefit?
Great question. So everyone's unique. Capacity assessments are only really required when the individual is either like we're in the hospital and we need to know if this patient has capacity for decisions, or if the family member believes that and the clinician believes that they don't have capacity, or there's a question about their capacity and the individual doesn't agree. In which case we would do a formal capacity assessment so that we know for sure whether or not the patient can make their own decisions in a thoughtful way. People are allowed to make decisions that we don't agree with, but they need to be able to back up those decisions, explain their reasoning, and consider all the alternative decisions. And so the times that a capacity assessment would be done would be if the individual is refuting the I guess assessment or the general assessment of the loved ones and the clinician, or in hospital, and there's a question of whether or not this person who no one knows in hospital has capacity. So if there's, I think my general advice, not knowing the unique situation, would be if you feel like your individual might not have capacity, or sorry, your loved one might not have capacity, and they feel like they do have capacity. Again, there's that symptom of dementia of not knowing the disease you have. Then I would go to your clinician and talk about getting a formal capacity assessment, and that will avoid some future headache moving forward.
Thank you, Dr. McInnis. There's a question here. It says there's a lot of shame and stigma around dementia that can further isolate people living with it and their caregivers. What are some ways we can reduce that stigma?
Yeah, great question. I think importantly talking about it, right? I think we could borrow what we've learned about mental health, for example, reducing the stigma by talking about it, having big campaigns where we're all engaged in that and reaching out to one another. So I think reducing stigma, just recognizing that, we're more, our person is more than just the functioning of our brain, right? There's so much more to us than our ability to remember details. And I think that caregivers, by reaching out and just knowing that we're here to support each other, is the best way to do that. But that social withdrawn, feeling socially withdrawn as an individual with dementia is, partly mediated by shame, but also the disease itself, right? It's really hard. Imagine listening to a conversation in a different language that you don't speak. It's really easy to tune out, right? So really good question. And I think that the Alzheimer's Society of Toronto and Ontario is exactly where you can connect about ways to reduce the stigma. There's a certain campaign going on. I've seen it advertised about participating in the Quest. And I think that's part of it, is just making people alerted to the fact that dementia exists and a lot of people live fulfilling lives with dementia.
Thank you so much. We have a question here about hospital visits and COVID. How do you deal with hospital visits, either for inpatient or outpatient care, if they're not capable of going in alone during COVID? How do you navigate accompanying them?
Yeah, good question. This is a moving target. Every hospital, depending on where you are, is doing a different thing, different stages. It's because of the lockdown and then opening it up and going to the color system. So the best way would be to pick a hospital that you're known and comfortable with. Oftentimes that would be one that's local. St. Joe's is very close here. Humber River, some patients go to. Or a hospital where lots of the loved one specialists are. That's a good one, because some people don't know this, but we don't openly share records between hospitals. So you can't go to Mount Sinai and expect that your hospitalization at St. Joe's is on the system. So do try to stick to one hospital. And in terms of navigating whether or not you can go in, it's just clearly stating that this is a patient with dementia who doesn't have capacity, and they will have to make accommodations because unfortunately your loved one can't speak for themselves. So I hope at this stage of the game there's ideas of working around it, and hopefully with the next month the lockdown starts easing. But showing up with the mask and just recognizing that it's all going to kind of depend on the hospital policy at that given time. I'm sorry to say, I don't have any good answers of that. I think everyone in hospital would really like it if, if they had someone there, but we are undergoing a pandemic right now and we have to keep everyone safe. So it's a balance.
Thank you so much. That's really helpful. There are a few more questions that have come in, but there's one that I want to get to, and I think this will be our last question. We really appreciate your time tonight.
Oh, no problem.
What are some of the specific impacts you see on caregivers, physical, emotional, or psychological? And are there support groups for caregivers?
Yeah, absolutely. And one thing I was thrilled to see were the support services in the Alzheimer group. There's a lot of support services that are actually targeted to caregivers. And it sounds like, you know, the person who asked the question is hitting on the main things, like, so signs of grief, right? You know, you're a caregiver with a lot of stress, but you're also recognizing that your partner is undergoing a very debilitating and devastating disease, right? So signs of grief and stress can present emotionally, but also physically. So feeling a fast heart rate, trouble concentrating, difficulty sleeping, increased anxiety. These are all signs of grief or trauma, right? And our caregivers are at risk of that, and working now with someone who, a loved one who doesn't have the capacity that they used to and have a lot more needs. And often with couples that are aging together, you know, we're contemporaries, right? So someone in their 80s with dementia is often being cared for, living with someone in their 80s, right? And of course, everything gets harder when we get older. So just be mindful of, if you feel like you're having trouble sleeping, if you're feeling more anxious, if you feel hopeless or feeling that you're unable to do the things that you used to do, you might be at risk of burning out. So just be mindful of what you have on your plate. Are you feeling overwhelmed? And know that there is support out there, and this is not an easy thing to be going through. Okay, so please be compassionate to yourself.
Well, thank you so much, Dr. McInnis. Thank you all for coming out this evening. That ends our time together. We really do appreciate your time, Dr. McInnis. This was wonderful, and the feedback is already coming in, so it's great.
Oh, that's great. Well, thank you for inviting me.
Not at all. Brian, you have a poll you wanted to put up, so did you want to give some information on that before we close things down?
Yeah, I will, absolutely. Just a very quick poll, 3 questions. Give us your feedback. For those of you asking if we could put the resource slides back up, I'll include them in the email that we send to you tomorrow. Look out for that, and we'll make sure that those are in there. Here's the poll coming up on your screen. Take just a moment. Let us know what you thought about tonight. Thank you so much for being here.